So my name is Joshua Wing, and I'm a nurse practitioner at Bayside Orthopaedics. And with us today is Jennifer Firestone, who's also a nurse practitioner with us. And we help coordinate and run the osteoporosis clinic with the surgeons here. Our surgeons are Dr. Terrell, Dr. Savage, Dr. Carter, and Dr. Detterman, and they will refer patients over to us along with other providers in the community who are at risk for osteoporosis or individuals who are at risk for fractures. And our goal is to identify these people before they fracture and treat them or optimize their nutrition and whatever it may be to help prevent fractures in the future. We're oftentimes not lucky enough to get to that point, and we see people who have already had fractures, and we identify these patients, work them up, figure out the why behind the fracture, and then treat them to help reduce their risk of having future fractures. Because after one fracture, your risk goes up pretty high over the ensuing 5-10 years. So I'll let Jennifer introduce herself too, so you can get used to her voice before she starts talking, and then we'll dive into the slideshow.
Well, welcome and thank you for joining in our live Facebook feed. We're excited to be here, and we're excited about bone health, and we are here for we are here to educate you about bone health and what you can do to promote strong, healthy bones for the future when we all age and our bones decrease in density.
Okay. Sorry, let me interrupt you. So this is a little bit out of norm for us going through the slideshows, and we can thank coronavirus for everything, but it also gives us a great opportunity to kind of work on prevention, and for everybody who has not had a bone health evaluation, kind of get the idea in their head, because every female over the age of 65 and every man over the age of 70 needs to be having a bone density study every 2 years to be looking at their density and identify if they're at risk, and if they're at risk, what we can do to help that. So here's a little picture to get an idea of who we are. Looking at the left is Bonnie Wilson. She's a nurse that works with us, and she is a huge contributor to this clinic. She helps us get medications approved. She'll be frequently calling patients, working with them, and getting in contact with them just to make sure everything's going well. So she's a huge driver of this clinic and a huge asset to us. In the center is myself, Josh Wing, and then to the right of me is Jennifer Firestone, who's a nurse practitioner and a huge asset to our clinic as well. All right, so this is kind of an overview of what we're going to be talking about. In essence, it's going to be talking about bone health, defining the disease of osteoporosis, and really just what is it. Comparing that to osteopenia and another very common disease of osteoarthritis that a lot of people confuse with osteoporosis. What are the risk factors for it? We'll talk about the DEXA scans. That's the DEXA you see there. And really what the DEXA scan is the bone density scan we look at. It's not a bone scan. A lot of people confuse a DEXA scan with a bone scan, but the DEXA or bone density scan. Then we'll talk about some nutrition and supplements we can look at to help with our quality of bone we build, and just medical management of osteoporosis. And then at the end, we'll kind of fall into the falls prevention aspect, which can help us reduce fractures as well. And then some educational resources for everybody that's interested in looking into it. Some different websites, different exercises, different dietary recommendations, things like that we can identify. Okay, so defining the disease. First, I want to go into how our bones work. So when we talk about bone growth, our bones are very unique in the sense of they're continuously breaking down old bone and building new bone. And if you can see my cursor here, there's some little purple cells that you see here, and these are osteoclasts. And these osteoclasts break bone down. Okay, so in this bone growth cycle, we break bone down with the osteoclasts, and behind those osteoclasts are osteoblasts, which rebuild the bone. And that's a normal process for everybody, and that's called remodeling. In this remodeling process, you will actually rebuild a skeleton every 7 to 10 years. So what you have now, if you're 55, when you're 65, you're going to have a different skeleton, different structure. That's why what we're doing today is so important to where we are in the future. So you're never too old or too young to start taking care of your bones, because if you have a 10-year life expectancy, by golly, we want to do everything we can to help our bones 10 years from now. So this is kind of just a view of the complex cycle of how our bones remodel. And if you look here, it kind of goes into more depth about bone growth. And there's a lot of people with children that may be watching, or grandchildren. And we can see that bone growth is pretty rapid throughout our childhood years and early adulthood until we get to about the age of 30. And in the slides, it'll say early 20s, late 20s is typically when we start meeting what's called peak bone mass. And that's very important because peak bone mass is the strongest our bones will be in our lifetime. Okay? So once we hit peak bone mass, we decline from there. So those cells that break bone down, these osteoclasts, work a little bit faster than these osteoblasts do. So our skeleton starts to decline in density, and we start to be more predisposed to fractures as we age. You can see in women, they typically have a faster decline. We men are a little bit luckier in that sense, but this is mostly related to menopause. So when women become postmenopausal, they have a decrease in the hormone estrogen. And by having a decrease in estrogen, we subsequently have a decrease in bone density, or an increase in those cells that break bone down. So it leads to a pretty quicker bone loss in our male counterparts. So peak bone mass is very important. And Jennifer has children, so she'll be able to better relate to us about nutrition and different types of foods that are healthy in calcium and vitamin D for kids. She'll hit a few now, and towards the end when we get into the nutrition and dietary side, we will kind of dive into a little bit more, but I'll let her go into the child aspect of it.
So as a mother, it is very important that our children get the proper nutrition that they need, so their bodies and all the processes can grow to their full potential. Children and adolescents that have higher peak bone mass in their youth, they actually have a reduction or a reduced risk of osteoporosis later in life. So this is extremely important. When you decide, moms and dads, when you decide what you're planning for dinner or what snacks, what have you, here are a couple of different things that are very high in calcium that can provide the calcium that they need. Yogurt is a big one. I know my children love yogurt, and they could eat a whole package of yogurt in one sitting if I would let them. So milk, one glass of milk is 300 milligrams of calcium. That is nearly half the calcium that they need in a daily setting. Cheese is big. I know kids like to eat cheese with crackers, so any kind of waffles and oatmeal. Orange juice also has a lot of calcium. So nearly all of these things that I've listed gives you a pretty decent amount of daily intake of calcium that they need. So it is extremely important to start early with your children to promote that bone health. So when later in life, they have that reduction of risk of developing osteoporosis.
Absolutely, yeah. And if your kids are anything like I was, I loved sardines, canned sardines, and sardines have good sources of vitamin D and calcium, and then a can of sardines is about 325 milligrams. So if your kids are one of those outliers like myself, sardines are a great source. So this next slide is talking about defining the disease. So what is osteoporosis? And what I tell every patient when they come into the clinic is osteoporosis is a condition that causes our bones to become weak or brittle. And that's the easiest way to describe it to people, is just weak, brittle bones. And you can see in this picture here that this is kind of what normal bone looks like. We had plans to show you some models, but through the Facebook Live we can't transition out of this mode. So this is going to be the best we have. But normal bone looks more dense. And you can see here this is normal bone with some little porosity inside of it. Then you get into osteoporosis. You start to see bigger holes and just weaker bone. And then here, obviously, this is severe osteoporosis, which when you get to this point, a fracture is pretty inevitable. You're at some point, if you fall, you're going to experience a fracture. So looking at the slide, we can all read osteoporosis translates into porous bone, and you can see the porosity is most significant here, but kind of is pretty severe here too, and you are at risk to fracture at all of these stages, but these two specifically put you at higher risk. So it's defined as a skeletal disorder characterized by compromised bone strength, predisposing to an increased risk of fractures. So I've put strength in bold, red, all caps, because that's very important for us to focus on, because oftentimes when we hear about osteoporosis, we think a bone density scan is all we need. And that's not accurate. A bone density scan is not all we need, because we have to look at the whole picture. Osteoporosis is a multifactorial disease, and it's not just that DEXA scanner, because these DEXA scanners can make mistakes, and the interpreters can have mistakes because we're human and it's technology. So when we look at strength, our bone strength is our density, which we assess from that bone density scan, plus quality. And quality of bone is what we see inside. So the quality of bone is the thickness of the bone. Obviously, better quality in this normal bone, very poor quality in the severe osteoporosis range. And we can assess quality through a couple of different ways. Specifically, your surgeon can assess quality when he's in surgery. And he can tell us, did they have poor bone quality? Did they have good bone quality? If you have a total hip or a total knee, things like that. We can also assess it and know you have compromised bone quality if you've had a ground level fall or a low traumatic fall and you've had a fracture. And that's what we call a fragility fracture. No individual should have a fracture from a standing height, meaning you're standing up, fall over, break your hip. That's not normal. Whether it's grass you fall in or whether it's concrete you fall on, that is considered a fragility fracture and is diagnostic for osteoporosis for hip and spine fractures. So silent disease is also important for us to understand too, because it is a silent disease. The first symptom or the first sign of osteoporosis is a fracture. And that's where our clinic comes into play in your primary care and orthopedist, because we want to identify these factors and get you in to discuss how we can optimize our bones before we have a fracture. But again, we're oftentimes not lucky enough to get to that point, so we want to address it whenever we can. So again, you're never too old or too young to be taking care of your bones. This is again looking at normal bone versus osteoporotic bone. You can see the porosity, as we mentioned earlier. It is obviously weaker, and you would expect to have a fracture in this bone before you would in this one. A good comparison is to discuss with people or discuss with patients and everyone the window seal. So you can have a brand new window seal that you go to open, and it's pretty on the outside. You open it up and everything functions great. Then you can have one in a 30-year-old house that's just been repainted and it looks good, but you go to open it. And that window seal is like this bone. When you open it, it crumbles. And it tells us that quality of that window seal, the quality of that bone or wood is not good. So this is like our termite-ridden bone that we look at here on osteoporosis, and this is our new 2x4 from Lowe's view of a bone quality. Common fracture sites, I'm sure some people viewing or looking at this later can relate to it. These are very common osteoporotic fractures. The most common we see are these distal radius fractures, spine fractures or vertebral compression fractures. Some people may hear compression deformities. That compression deformity is a compression fracture, and that is diagnostic for osteoporosis if it was sustained from a ground level fall or low trauma, or some people don't even know they have them, and we identify them once we bring them in for the evaluation. And then multiple categories of different hip fractures that may require a hemiarthroplasty, intramedullary nailing, plating, things like that, pins, all very severe and warrant further referral to be evaluated for bone health. We really want to get you in if you've had a fracture and be evaluated and treated. So why are we concerned? I'll let Jennifer talk a little bit about the statistics. The ones that really stand out to me that I tell everybody is this one up top. 1 in 2 women And I usually tell people 1 in 4 men, but 2 in 4 men will experience a fragility fracture or osteoporotic fracture after the age of 50, which is remarkable. And I'll let Jennifer take over the rest.
Mm-hmm. So it is pretty remarkable. So at least one osteoporotic fracture happens every 3 seconds, and that's huge. And if we can do anything to prevent fracturing, one of the main things would be to prevent falls. But to prevent falls and to build stronger bones would definitely prevent some osteoporotic fractures. 80% of people who have an osteoporotic fracture or a fragility fracture are not identified or treated. 25% will likely die in the first 12 months following a hip fracture, and that is a very, very large number. So that's within 6 to 12 months that 20%, 25% of patients will die. Any previous fracture is associated with an 86% increased risk to fracture again. And then the mortality rate or percentage increases even higher. In women over 45, osteoporosis accounts for more days in the hospital than any history of diabetes, heart attack, breast cancer combined. So that is a huge economic hardship as well when you look at overall osteoporotic fractures.
So yeah, that is pretty remarkable. And one of the biggest things, I've been in orthopedics for about 5 years now as a nurse practitioner, and initially started out working just in surgery. And I would see these people who come in with a wrist fracture, and then a year later they come in with a hip fracture, and then another hip fracture or a fracture around that hip replacement, and that really started to concern me. And I have seen this statistic where the 25% mortality risk within the first 12 months, and it tells us how severe this disease is. This disease can kill you. Mm-hmm. And it's not the fracture that necessarily kills you, but it's the other comorbidities that come associated with that fracture. We're at risk for blood clots, we're at risk for heart attack, stroke, things like that can exponentially increase our risk of dying. And this statistic here, 80% of people who have an osteoporotic fracture are never identified or treated. So these hip fractures, these spine fractures that come out of the emergency room or hospital, only 20% of these patients get a bone density scan, or if they've got it, get treated for it. And we have the evidence to show that once you have a fracture, your risk of having a fracture is exponentially higher, and we have the medications to help reduce your risk. So we want to absolutely do everything we can to help reduce our risk of having a fracture. And here's some factors that affect our bones. Specifically, you hear most about being older, so postmenopausal. If you're a smoker, it puts you at risk. Family history is a non-modifiable risk factor too. So if your mother or father had osteoporosis or a hip fracture, it puts you at a 4-fold increased risk to have the disease. Excessive alcohol usage, poor dietary intake or dietary choices, sedentary lifestyle, lack of resistance exercises, which falls into the sedentary lifestyle, and increased risk of falling also increases your risk of fractures. There's a lot of diseases too that affect our bones, like breast cancer, rheumatoid arthritis, celiac disease, different GI surgical procedures like a gastric bypass, diabetes, and premature menopause, and then medications as well. And oftentimes it's unavoidable that we have to take the medications and we can't get off of them. But it also gives us an understanding that there's a risk, and we can hopefully identify that risk and work at other ways to help improve our bone quality. So this is kind of just an understanding of the silent disease process. So hypertension and diabetes is a good comparison. Oftentimes you don't feel or see the symptoms of it initially, like prediabetes, but we treat it. And we should be looking at osteoporosis in a similar viewpoint, that we have a risk to fracture, and watching it's appropriate in some situations, but oftentimes we want to treat it and go on medications to prevent our bones from getting any worse. So just because it's a silent disease and you don't feel it doesn't mean that it doesn't need to be addressed. And that's where you contact your healthcare provider, your bone health specialist, and discuss the options available and what we can do to help this. I mentioned earlier that we were going to talk about the comparison of osteoporosis and osteoarthritis, and I didn't touch on that, so I apologize, but I'll go ahead and go into osteoarthritis and what that is. Osteoarthritis is a condition that affects our joints, and it's usually a degenerative disease where it affects the joint cartilage and can be a bone-on-bone contact that causes more pain, and that is symptomatic. You do feel pain with osteoarthritis. Osteoporosis is a condition of the bone structure, so the bone strength. You don't necessarily feel it until you fracture, but it is of the bone and is of bone quality. Okay, DEXA scans. So historically, we've looked at DEXA scans or bone density scans for the diagnosis of osteoporosis. And Jennifer will talk into a little bit about the bone densities of what's normal, osteopenic, and osteoporosis. But the main point we want to take away is this is not the tall tale sign. We see more fractures in this osteopenic population than we do in the osteoporotic population based on bone densities. And that's because for years we hadn't looked at what quality of bone is. What is that quality of bone we need to identify in conjunction with osteopenia that can put you at risk.
So with DEXA scans, they use typically they use 3 sites to determine your bone density. They'll use your hip, your femoral neck, your spine, and your wrist. And they look at these numbers and determine what the density is. So a normal density is anything greater than negative 1.0. Osteopenia, which is low bone mass, it's not osteoporosis quite yet, but low bone mass or osteopenia is any range of negative 1 or less, equal to negative 2.5. Osteoporosis is diagnosed when you have a bone density less than negative 2.5. Severe osteoporosis is a osteoporotic T-score of less than negative 2.5 with a pathologic fracture. So that is anything from a hip fracture, a wrist fracture, a spinal compression fracture, any kind of ankle fracture, or any multiple stress fractures in osteoporosis can be qualified as a severe osteoporotic fracture.
Absolutely, and she hit the nail on the head about the severe osteoporosis, and we really want to identify on that. But when we look at osteoporosis too, we can diagnose somebody with osteoporosis based on the bone density score in this osteopenic range if they've had a fracture. And also, if you are at a very high risk, you have a high risk calculation and you're osteopenic, that puts you in the criteria of osteoporosis too. Again, kind of jumping back to where we were earlier, you can have a normal bone density and you can fall from a standing height and break your hip or spine, and that is automatically diagnostic for osteoporosis too. And we put this red light here because it kind of tells us normal, green. Osteopenia is yellow because, again, a yellow light means caution. We don't blaze through every yellow light we see, or we shouldn't. We need to be cautious once we get to this area because oftentimes it can turn to red very, very quickly, and we don't understand when we get there that we're at that high risk of fracture. So I'll have patients who come in who are negative 2.3 and negative 2.4, and that small difference in the standard deviations between negative 2.4 and negative 2.5 dictates whether we treat them or not. Well, we need to look at the whole picture and understand that this is a multifactorial disease and that we need to really identify everything going on and look at the person, not the score. So this is just talking about the International Society for Clinical Densitometry, or ISCD, talking about what sites we look at, as Jennifer hit earlier, the wrist, spine, and hip. The main stressor in this is that there is one single diagnosis reported for each patient. So if you have a negative 1.0 T-score in your spine and then a negative 2.5 in your hip, well, you have osteoporosis. That's not you have osteoporosis of your hip. You have osteoporosis, and you need treatment because it tells us that you're at risk to fracture, and we need to treat your whole body. Again, treating the person, not the number. Big topic here: nutrition and supplementation. Takeaway point: eat the colors of the rainbow. Okay, eat 4 colors every meal. Eat the rainbow every day because we want to make sure you're getting plenty of calcium, protein, vitamin D, etc. And some people may have restrictions, dietary restrictions, and that's where you consult with your healthcare provider, your nephrologist, your diabetic educator, your primary care physician. But you want to consult with your doctor before you start diving into these foods heavily because we don't want to risk compromising any other underlying diseases that may contribute to bone loss too. But colors of the rainbow for a normal, healthy individual is what we want to focus on: fruits, vegetables, protein. Supplements, we hear a lot about vitamin D and calcium. There's some other supplements we didn't talk about, like strontium and vitamin K. And I personally don't typically recommend strontium for patients for different reasons. They are on the same row of the periodic table as calcium. However, they're more dense and they can increase bone density, but they don't necessarily reduce our risk of fractures with strontium. So that's why we typically discuss that with the patients and figure out why they're taking it and if they're a candidate for it or if not. And that varies patient to patient. But vitamin D and calcium supplementation are 2 big topics that we talk about and that we need to identify. Again, some people may not be a good candidate for calcium supplementation because they may have pre-existing high calcium levels or they may have an underlying issue that they don't tolerate calcium. So it's something to discuss with your bone health specialist or your primary care doctor in regards to. This is the recommended daily allowance for calcium and vitamin D, and Jennifer hit this earlier about some foods that are healthy in calcium and vitamin D, and then the recommendations here.
So, the recommended daily allowance of calcium, it does differ depending on your age. However, women under 50 will need at least 1,000 milligrams of calcium a day. If you're greater than 50 years old, you need at least 1,200 milligrams. This is food and supplements. Okay, so you can get 600 milligrams of calcium through diet, and then you can supplement the other 600 if you're greater than 51. So that would mean you could drink 2 glasses of whole milk, 8-ounce glasses of whole milk. They're 300 milligrams of calcium each. That would give you 600 right there. And if you wanted to supplement the other 600 because for some reason you're not getting calcium elsewhere in your diet, then that is completely acceptable. For men less than 70 years old, they also recommend 1,000 milligrams of calcium a day. And then greater than 71, 1,200 milligrams as well. Things that we can also think about, the colors of the rainbow: green leafy vegetables, collard greens, broccoli, kale, your seafood, sardines, like Josh likes, salmon and shrimp. And then you also obviously have your dairy, like milk and yogurt, cheese, ice cream. If you're like me, you would like to eat a whole bucket of ice cream. Fortified foods such as waffles, your oatmeals, cereal, muffins, English muffins, and then other things, noodles like macaroni and cheese. I mean, you can get pizza actually has calcium in it. It has 115 milligrams given the cheese that's on it. So we get a lot of calcium from our diet that we may not necessarily realize. But as far as our vitamin D, we can get that through our food, and we can also supplement it as well. It is recommended that women less than 50 years old get at least 800 international units of vitamin D daily, and greater than 51, 1,000 units of vitamin D. Men less than 50, anywhere from 400 to 800 international units, and greater than 50, at least 800 to 1,000 international units. It is difficult to get the vitamin D that we need from food and sunlight. So Typically, we do have to supplement with vitamin D in order to reach the recommended daily amount. With saying that, it is typical that we do supplement with the calcium and the vitamin D in conjunction with a proper diet.
So sometimes calcium and vitamin D is not enough to help our bones, and we've gotten to the point where our bones aren't growing as strong as we need them to. So we have to look at medications, and these medications are for osteoporotic patients or people who are on that edge that are at risk to fracture. And there's historically there's two classes: the anti-resorptives and the anabolic medications. And these medications are different in the sense of the anabolics regrow our skeleton. So these help regrow bone, whereas the anti-resorptives help prevent our bones from breaking down anymore. So they help prevent bone loss. If you have somebody that comes in with a hip fracture or spine fracture, and they obviously have poor bone quality, we want to regrow that bone first, and we want to be looking at anabolic drugs, because once we regrow that skeleton after 2 years of treatment, we want to go to a medication that prevents that bone from breaking down anymore to sustain our skeleton, because our body's already proven to us that we can break down bone pretty quickly. So we don't want to invest 2 years in this medication and then have it break right back down to where we were. These medications, the anti-resorptives, are your bisphosphonates, your Prolia, which is a medication we've all probably seen the commercial on, or denosumab. And the bisphosphonates really fall into the class of Reclast and Fosamax. You hear those two the most. And if you Google them, a lot of people see scary side effects associated with them. I like to talk to every single patient personally about these side effects, because oftentimes our risk of having a fracture is exponentially higher than the risk of developing these side effects that people worry about. However, it's not to say that they're not real. They do happen. And we talk about it, and if anybody is at an increased risk, we dive into it even more, and we talk about it, and we never do anything until the patient's comfortable. And then anabolics, great drug class. Again, regrow bone, very good for patients who have fractured or at a very high risk to fracture. And then there's a new medication that just came out recently over the past year called Avinity, and it's kind of a combination of these anabolic drugs and the anti-resorptive drugs. So it regrows the skeleton and also helps prevent what we're growing from breaking down. And this is just a year duration, so it's an injection every month for a year. And when a patient comes in for an evaluation, bone health evaluation, we dive into these medications thoroughly, and we discuss them in depth and discuss risks, benefits, alternatives, and answer any questions they may have in relation to them. Falls prevention, very, very important for our older adults, our grandparents, parents, ourselves, whoever it may be, to reduce our risk of fractures. Because if you have bad bones and you fall, you're at a risk to break something, and you probably will. So our goal of falls prevention is to reduce sarcopenia, which sarcopenia is just muscle wasting, to build bone and to prevent falls. So resistance and balance, we want to improve our strength, or the purpose of the resistance and balance is to improve strength, decrease injury and pain associated with falls, decrease the risk of falls, and decrease compensation. Here's a few things to help with strength and help with falls prevention and all. Specifically, fresh, healthy foods. Again, the colors of the rainbow. Keep moving. Don't have a sedentary lifestyle, because that is a modifiable risk factor in some people that can help improve our bone strength. We want to be doing things like walking, Tai Chi, things to help with balance, core strength, and wear sensible shoes. This is one of the most important things, because when I talk to these hip fractures in the hospital, or these ankle fractures, spine fractures, and ask how did you fall, a lot of them slipped in the kitchen, or slipped on a rug, or tripped over a cable, or they were wearing flip-flops. If you're at risk to fall already, wear non-skid soles in your shoes. Avoid things like flip-flops. Don't have throw rugs out that you can slip on and increase your risk of falling. Make sure you have good lighting in the house so that you can see what's in your path. And again, remove the home hazards like throw rugs, cords, things like that may increase your risk. And if you're unstable on your feet, number one, our therapists are essential. If you're unstable and you're having issues with balance, you need to see a physical therapist, and you need to get in to work on balance gait training. My wife's a physical therapist. I have a lot of friends, close friends who are physical therapists too, and I praise their efforts and what they do, because it is very, very important to what we in orthopedics do and what we in the bone health community do, because improving balance and strength helps reduce fractures. Use of assistive devices too, again, if you're unstable, in conjunction with therapy. If you need things like hand rails, grab rails in the shower or tub, if you need a walker or a cane, learn how to use it correctly, learn how to use it effectively, and let's reduce our risk of fractures. And then review the medication list. A lot of medications can put you at risk for falls, and just being aware of those can help reduce your risk overall. So educational resources, there's a lot of resources in the community that patients, providers, everybody can refer to get an understanding of what you can do from an exercise, dietary, evaluation, and just general community connection to get with other people who have had osteoporosis, or discuss on chats with them. And some great resources that I utilize personally, and I know a lot of patients utilize, are the National Osteoporosis Foundation and the International Osteoporosis Foundation. Those are two great resources. And if you have any resources, if you have any resources that we didn't list or that you have used that are very beneficial, put it in the thread too, and just let some other people know about it. Jennifer and I both have osteoporosis clinics or bone health clinics at Bayside and Fairhope and Foley. And to give you an understanding of what we do in our clinic, you come in, you fill out a questionnaire to give us an understanding of what your bone quality is. And then we sit down with you for 45 minutes to an hour, and we talk about from A to Z, from birth till now, what's been going on in your bones and what we have what you have experienced that can affect your bone quality. And we address these, and we work on modifying the modifiable risk factors, and the non-modifiable risk factors we discuss. And we discuss on how we can change other processes in our life to help the bone quality as we move forward. We also figure out the why behind fractures, or why behind our risk of fractures. And we get labs to rule out what we call secondary causes of poor bone quality, or secondary causes of our osteoporosis. And then we have you come back and we sit down and discuss those labs in detail. We communicate with your primary care very closely and your OBGYNs, and we make sure they're aware of everything that we're doing through this process, and get their recommendations too. Another very important resource for us are the dentists and oral surgeons. If you have concerns or questions about the medications that are on board, we'll talk to your dentist if we have to. But again, everything's individualized and patient to patient. We can't just look at it from a whole and say everybody needs calcium, everybody needs vitamin D, everybody needs a medication. We need to sit down, discuss it, and talk about it.